In this next introductory section, Principles of Pharmacology 2, we will be discussing primarily metabolism of drugs. The next section is entitled The Principles of Pharmacology number 2, and we'll be talking about mostly metabolism of drugs. Drug metabolism in the body is also referred to as biotransformation, and the purpose of this is to convert the molecule that you take in to a more water-soluble metabolite that is more readily excreted. Remember that the body sees chemicals such as medications as foreign particles, and therefore does its best to change them into forms that are more easily excreted. Remember that metabolites of drugs may have no pharmacologic activity. They may have similar pharmacologic activity to the compound that is taken in. They may also be toxic metabolites, or some combination of the above. It's important to remember that biotransformation, or metabolism of medications, does not always inactivate the drug. Prodrugs are drugs that we take in that depend on biotransformation, or metabolism, to activate the drug. The most important example of this would probably be azathioprine, which is converted in the body to 6-mercaptopurine, which is an anti-cancer agent. Codeine, which is a very commonly given over-the-counter medication, is a prodrug of morphine. It is converted to morphine in the body. Valacyclovir is also a prodrug of acyclovir that has a much higher bioavailability than acyclovir itself. That's why it's given. It is converted in the body to acyclovir. Phase 1 biotransformation involves the modification of the drug via multiple chemical reactions, including oxidation, reduction, and hydrolysis. Phase 2 biotransformation involves conjugation with endogenous compounds via transferases. This is also referred to as synthetic biotransformation. It also requires a reactive group on the molecule, such as a hydroxyl group, that these conjugation reactions can occur at. In general, a medication is given to a patient and then undergoes phase 1 transformation. However, some medications skip directly to phase 2 transformation. After phase 1, remember that the drug is not only deactivated, but some medications may be activated or unchanged. Whereas after phase 2 biotransformation, generally the drug is considered inactive. Here's an example of aspirin going through 2 phases of biotransformation. As you can see, aspirin, which is a prodrug for salicylic acid, is converted by the loss of this methyl group. After aspirin is conjugated to a glucuronide group, it becomes more water-soluble and therefore leaves the body more quickly. The cytochrome P450 enzyme system is a system that you'll have to know for step 1. It is involved in phase 1 biotransformation. The enzymes of the cytochrome P450 system are located mostly in the liver. However, they're also located in the GI tract, lungs, and the kidney. The cytochrome P450 enzyme family is extremely elaborate. The major enzymes that you should remember are cytochrome 2D6, 3A4, and 2C9. 3A4 is involved in the metabolism of steroids, vitamins, and over 50% of all drugs that are prescribed in the United States. That's why we consider 3A4 to be the workhorse of the cytochrome P450 family. 2D6 is also important because it shows significant genetic variation between individuals. It's also very important. It metabolizes about 25% of prescribed drugs. Again, 3A4 is the workhorse of the cytochromes. It can metabolize many different drugs as well as endogenous compounds such as steroids and vitamin D. Cytochrome 2D6 is responsible for metabolizing tricyclic antidepressants as well as antipsychotics, beta blockers, and opiates. And as you can see, it would be very important to know the concentrations of these drugs in patients that have genetic variation. Remember, 5% of the population will be poor metabolizers, meaning they have very little or no cytochrome 2d6 activity. And these patients will be very sensitive to tricyclic antidepressants or beta blockers. Or, for example, for patients that are taking codeine, they would not be able to convert that codeine into morphine and therefore would not get pain relief. On the other hand, 5% of the population would be ultra-rapid metabolizers, and therefore they would metabolize these drugs very quickly and would not get the benefit. Except for codeine, you would see fast conversion of the codeine medication to morphine. Cytochrome 2C9 is the enzyme that breaks down Coumadin or warfarin. It's important to remember that every patient is different with regard to their ability to break down Coumadin, and therefore we have to check PT and INR in these patients because each patient will have a different INR after 1 or 2 doses of warfarin. It's important to remember that certain medications and foods may either induce or inhibit the cytochrome P450 system. These are the drugs and foods that can cause drug-drug interactions. It's very important to remember the following medications as inducers of the cytochrome P450 isoforms. The classic inducer is rifampin, which is an anti-tubercular medication. Also, the anti-seizure medications such as dilantin, carbamazepine, and phenobarbital, as well as St. John's wort, which is an over-the-counter herbal medication. It's important to remember also that a drug that may induce cytochrome P450 expression in the liver may also induce its own metabolism, and this is seen with carbamazepine, meaning it increases the activity of cytochrome P450 and therefore is able to degrade itself more quickly because it has activated its own enzyme. Remember that cytochrome inducers will increase the degradation of a number of other drugs, including, most importantly, oral contraceptives. One example of a classic board's question is a patient who is on oral contraceptive therapy and starts to take rifampin. This rifampin activates cytochrome 3A4, which metabolizes the estrogen in the oral contraceptive pills, and the patient does not receive the benefit of the contraceptive therapy and therefore becomes pregnant. In another patient who is receiving cyclosporine, which is an anti-rejection medication, following an organ transplant, going on one of these medications, such as rifampin, can lead to more degradation of the cyclosporine and possible rejection of the organ. There are also medications that are cytochrome P450 inhibitors. All of the medications that are related to ketoconazole, which are antifungal medications, these are classic cytochrome P450 inhibitors. These medications work in fungi by inhibiting the fungal cytochrome P450 so that the fungus is unable to make ergosterol. Unfortunately, they also crosstalk into the human cytochrome P450 system. Other medications that can inhibit cytochrome P450 include cimetidine, the H2 blocker, erythromycin, and Bactrim, or trimethoprim sulfamethoxazole. This is a pharmacokinetic study that was carried out in a patient population where half of the patients were taking cimetidine and half were not. All of the patients were then given theophylline. And as you know, cimetidine is a cytochrome P450 inhibitor. Therefore, a medication such as theophylline that relies on cytochrome P450 for its degradation would experience higher levels when the patient was taking cimetidine. And as you can see, there's a significant difference between the patients that were taking this cimetidine as opposed to the patients that were not. Grapefruit juice is also a cytochrome P450 inhibitor. Grapefruit juice leads to potentially toxic levels in patients that are taking cyclosporine or tacrolimus. Tacrolimus is an immunosuppressant medication that is designed to prevent rejection. The concept of pharmacogenetics or pharmacogenomics is based on the idea that every individual is different in their ability to metabolize medications. Patients are also very different in their ability to respond to medications. And there are many different enzymes which may vary from person to person. Not only the cytochrome P450 enzymes, but an enzyme such as N-acetyltransferase. And this gives rise to the concept of the slow versus the fast acetylators. Some patients are slow acetylators, and they're not able to break down medications using this enzyme. Other patients are fast acetylators, and they very quickly break down medications through this enzyme. So the activity of the enzyme may change from person to person based on mutations in that enzyme. Phase 2 biotransformation refers to the processes that may occur after a phase 1 reaction or may occur directly. And they include transformation of the molecule into a conjugate. And this may include glucuronidation, acetylation, sulfation, or glutathionation. In general, phase 2 biotransformation inactivates drugs. There are very few drugs that have active conjugates. One example would be morphine, in which the 6-glucuronide conjugate of morphine is active in pain control. Glucuronidation is seen with many medications such as acetaminophen, chloramphenicol, and morphine. Glucuronidation is also inducible by rifampin. Neonates have decreased ability to glucuronidate molecules because they have a lower activity of the enzyme that's responsible for this. That's why it's important to not give infants medications that require glucuronidation for inactivation, such as chloramphenicol. This can lead to gray baby syndrome. Acetylation involves the enzyme N-acetyltransferase. This is a very important concept to remember in that certain patients may be fast acetylators or slow acetylators based on the activity of this enzyme in their body, based on certain mutations in the enzyme. Patients that are fast acetylators will break down medications such as hydralazine, procainamide, and isoniazid because these drugs rely on N-acetyltransferase for their metabolism. However, slow acetylators will be more prone to side effects from these medications because these meds will hang around longer in the body. This is a distribution curve that shows a certain population. And it shows in the purple on the left, these would be the rapid acetylators or fast acetylators. And on the right, you have the slow acetylators. And a drug like isoniazid, which relies on acetylation for its breakdown, will last a long time in slow acetylators as compared to rapid acetylators. Sulfation, another phase 2 reaction, is used to break down certain medications such as minoxidil and steroids. The enzyme in the body that's responsible for sulfating drugs uses as a substrate the molecule PAPS, which adds a sulfate group to the drug. Generally, this is thought to inactivate drugs. Glutathionation is another very important phase 2 reaction that's especially important for the metabolism of one of the most popular drugs on the market today, acetaminophen. When patients overdose on acetaminophen, it will deplete the liver of the enzyme that's responsible for putting the glutathione moiety onto the acetaminophen molecule. This causes an abundance of acetaminophen, which then must be converted by another pathway, which is normally minor, to a toxic metabolite. These patients should be treated with N-acetylcysteine, and we'll talk more about why that's very important. N-acetylcysteine is a reducing agent that is able to substitute thiol groups into the body. Elimination is a term that describes the removal of the drug from the target tissue and the body. And as you know, major modes of elimination involve the kidney, the biliary system, the lung, and by sweat. This curve again shows that medications will go through initially a distribution phase and then an elimination phase. On the x-axis, you can see time after administration of the medication. And in the y-axis, you can see the log of the drug concentration. Over time, first the medication redistributes into the plasma, and then the medication is slowly excreted or eliminated from the body. So over time, the concentration of the medication will go down. Using this curve, we can extrapolate C0. C0 is very important to determine the volume of distribution. So looking at a curve like this, you take the elimination curve and extrapolate it onto the y-axis. And that gives us a serum concentration at time 0, in this example, of 1. This C0 is a false value, meaning it never actually existed. However, because all medications require a distribution phase, it's impossible for us to measure the C0 directly. Therefore, we must use this curve to extrapolate it. When medications are eliminated from the body, they may use different kinetics. And those of you that have a background in mathematics and physics may recognize this. It's the same concept. Certain medications use zero-order kinetics for elimination, and other medications use first-order elimination kinetics. The concept is quite simple. Medications that follow zero-order kinetics show elimination that occurs at a constant rate and is independent of the drug dose and the concentration in the plasma. Other medications that follow first-order kinetics will have elimination that varies proportionally with the concentration of the drug in the plasma. We'll talk more about this. The majority of the drugs follow first-order elimination kinetics, as long as they are at therapeutic doses. All medications at very high doses will show zero-order kinetics. And the reason is because you've given so much medication that you've saturated the body's ability to break it down and to eliminate it. Other medications will show zero-order elimination at therapeutic doses. And for example, those would be phenytoin, ethanol, and salicylates. The most important example of this would be phenytoin or Dilantin, the anti-seizure medication. This is the chart that shows zero-order saturation kinetics. On the y-axis, we have blood alcohol concentration. And on the x-axis, we have time. And as you can see, if a patient is given a certain amount of alcohol, this patient in this curve was given more alcohol than the patients below it. But as you can see, the slope of the line in each patient is the same. This shows that the rate of excretion is the same in each patient, no matter what the dose was and no matter what the concentration was in that patient. It's very difficult to dose medications that have zero-order kinetics. However, with first-order kinetics, eventually these medications will easily form a steady state. And that is because as the concentration goes up of that medication, the rate of elimination will go up as well. So the higher the concentration in the body, the more the body would like to get rid of the medication, which makes it easier for the body to form a steady state concentration. With saturating kinetics, also known as zero order, these medications are much more difficult to dose, because what happens in these medications is you'll give a certain dose, but the body will not eliminate it faster as the concentration increases. The concentration will go up, but the elimination will stay the same. And therefore, as the concentration increases, the body may may be exposed to very toxic concentrations of the medication. Here's another example of how this may work. In zero-order kinetics, the medication is given, it reaches the therapeutic range, but the medication is still administered to the patient, and the medication enters the toxic range very quickly. The elimination half-life of a drug is defined as the time needed for that drug for the body to eliminate 50% of the amount of drug that's given, or to decrease the plasma concentration or level to 50% of a former level. If a drug shows zero-order metabolism, you cannot measure the half-life. Here's an example of a medication that uses zero-order elimination as you try to determine what the half-life is. In this patient, you initially gave 100 milligrams of a medication to a patient. You would wait for the plasma level to reach 50 milligrams per whatever unit volume. And you showed that it took approximately 30 hours. So your half-life for this medication would equal 30 hours. However, if you were to give 60 milligrams of the same medication to the same patient, you would wait for the medication to reach 30 milligrams and then calculate your half-life, which would equal 18 hours. This is because in zero-order elimination, every 6 hours in this example, 10 milligrams is eliminated. This shows that the rate of elimination, 10 milligrams per 6 hour, is not dependent on the concentration because it's zero order. And therefore, we cannot measure the half-life. We are, however, able to measure half-life when a drug undergoes first-order elimination. Suppose we administer 100 milligrams of the drug, and then we measure the level of the drug at 6, 12, 18, and 24 hours. If 50% of the drug is eliminated every 6 hours, as you can see, every 6 hours you lose half, then we can say that our half-life is 6 hours. Clearance is a concept that is defined as the volume of blood cleared of the drug in unit time. Again, this is not a real value, but it's very clinically important. Clearance is the relationship between the rate of the drug elimination and its plasma level. The formula for clearance is basically clearance equals the urine flow rate times the concentration of the drug in the urine over the steady state plasma concentration. Most likely you will not have to calculate this on step 1, but it's important to remember what the concept of clearance is. The steady state concentration occurs when the rate of the drug in equals the rate of the drug out, meaning how quickly is it being administered versus how quickly is it being broken down or eliminated. The time to reach steady state is dependent only on the elimination half-life of the drug. If you give more of a medication and give it more often, it will affect the concentration reached at the steady state, but it will not affect the time needed to reach that plateau. And we'll talk about that right now. Although it takes greater than 7 half-lives to actually reach the mathematical steady state, in general, a drug reaches its steady state always by approximately 4 to 5 half-lives. As you can see here, if you give a medication at different intervals, so a medication is given here, 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 and so on, at the same dose, the average plasma concentration, which is shown by this straight line, will eventually reach a steady state. This is in a drug with first-order elimination kinetics. The time that is needed to reach that steady state is independent of dosage. It's only related to the half-life. The rate of infusion of the drug will determine the plasma level as you reach steady state, but it again does not change the time needed to reach that steady state. Here we show the same medication given to two different patients. However, the curve on the top shows a higher rate of infusion. The curve on the bottom shows a lower rate of infusion. Both of these patients reach steady state at approximately the same amount of time. However, the patient that receives the higher rate of infusion will have a higher steady state value than the patient that had a lower rate of infusion. Along the same lines, the drug elimination curves will show that the half-life of the drug does not depend on the size of the dose that was given to the patient. Here we have two different patients, one who received 100 milligrams of a drug and another patient who received 50 milligrams of the drug. And as you can see, both patients have the same half-life. For example, this patient took this much time from here to here to reach half of the plasma concentration at time 0. That allows us to calculate the half-life from both of these points. The same patient over here went from 50 to 25 in the same amount of time. Therefore, because the same drug was given to both patients, the half-lives are the same. Repeated dosing versus single dosing is a very important concept in pharmacology. If you give a patient a dose of a medication and it's a repeated fixed dose, the repeated oral administration will cause oscillations to occur, as you can see in this orange line. But eventually, they will reach a steady state. And as you can see, each bump represents a different administration of the same medication. The steady state concentration is influenced by how quickly the drug is eliminated, how much is given, and how quickly it's absorbed. The same medication, however, that's only given once will cause a spike, and then the amount will trickle down. Therefore, in order to reach a therapeutic level of a concentration of a drug in the blood, you must give the medication at a certain fixed interval over and over again. In general, medications do not reach therapeutic level after just one administration. There are some exceptions to this rule. A loading dose of a drug is usually a higher dose than the daily dose that you'll be giving that patient. And that loading dose is used to rapidly achieve effective blood levels, especially for drugs that have a long half-life. Remember that these patients will not reach steady state faster, but they can get to the therapeutic concentrations more rapidly using a loading dose. In order to calculate for intravenous administration how much loading dose you should give a patient, you need the volume of distribution and the desired plasma concentration of that medication. That will allow you to calculate exactly how many milligrams of the drug to give. For oral administration, you also have to take into account bioavailability, which is referred to here as F. For intravenous administration, bioavailability equals 1 always. But for oral administration, remember that bioavailability is usually less than 1. At a steady state level, in order to calculate the maintenance dose, you have to remember how much of the drug is put into the body is equal to the amount that's eliminated. Therefore, the rate of administration will have to equal the steady state concentration times the clearance of the molecule. The higher the clearance, the more and more quickly you'll have to give the medication in order to reach a steady state concentration. In order to calculate the infusion rate of a molecule, it's easiest to tell in a patient that will be receiving a constantly infused medication. For example, in this case, we have a drug that has a certain clearance, and you will be given that clearance on the test. What we'd like to do is, in this patient is to maintain a steady state concentration of 5 milligrams per liter of plasma. This is the level of the drug we would like to achieve in that patient in order to achieve an effect. The rate of the administration equals the steady state concentration times the clearance. And that will give us our infusion rate. It's important to remember your units, however. As long as your units add up, you can simply multiply these two values, and that will tell you how many milligrams per hour you will have to infuse of that drug in order to keep this plasma level. It is more difficult to calculate discontinuous maintenance dosing. Here we have the same medication with a clearance of 20 liters per hour, and we're desiring a plasma concentration of 5 milligrams per liter. But we only want to inject the drug every 8 hours. We don't want to give it constantly. Again, the rate of administration is equal to 100 milligrams per hour. In order to figure out how much we should give every 8 hours, we simply multiply this by 8. So 100 times 8 is equal to 800. And this will last the patient for 8 hours. What this will result in, however, is a sinusoidal curve instead of a flat curve in the concentration over time. But it's usually more efficient for the patient to only receive a medication every 8 hours instead of being on a constant drip. This is the last slide in this section. This concludes part 2 of 3 of Introduction to Pharmacology.